Hi, I'm Joe Broderick from the University of Cincinnati, and it's my delight to talk to you and interview the investigators from the C3FIT study, George Howard and Mark Alberts. And maybe we'll start first with George and say, what is it about C3FIT that makes you excited? What do you think it adds to the literature?
Well, we're of course delighted to be here and to represent the study and the investigators, and frankly also to represent Dr. Ken Gaines, the principal investigator for the study, who unfortunately could not attend the meeting this year. But we are very proud and excited to be finishing this study. What we're trying to do is to evaluate the impact of improving the communication across the spectrum of stroke care, beginning with acute stroke care and going all the way through the long-term care for stroke patients, the multi-year follow-up of the patients. And hopefully that will improve both their quality of life and also their functional outcome. And what we found was that this better communication, led by people like Dr. Alberts, substantially improved the control of risk factors, much better blood pressure, much better diet, substantially better LDL levels, and trends for better exercise and other factors. But unfortunately, Joe, we didn't show a difference on the functional outcome or on the quality of life outcome. And we have personal beliefs and biases for why we think it didn't show the effect. I will say that I believe improving somebody's blood pressure will have an impact. And so I was surprised by the findings. Mark?
I think one of the other secret findings, as George was saying, is that in the intervention group, we were able to form a multidisciplinary integrated team that actually went into the patient's home on a monthly basis to see how they were doing clinically, to make sure they were taking their medications, and to solve some boots on the ground problems that these patients encountered. So I think by taking this multidisciplinary comprehensive approach for the intervention group, we were able to achieve some of the clinical outcomes that George was speaking about.
So I think when we were talking earlier, it was clear that the centers that were participating were already kind of comprehensive places, and which means that when you're trying to affect outcome and you're randomizing one group to kind of what you already do, which is maybe not so bad, to something that's even more intensive, it may be hard to find a difference in outcome. I don't know what you guys.
Before Mark answers, I have to say I enjoy being with someone who considers a comprehensive stroke center a not so bad quality of care. It must be wonderful in Cincinnati, but
yeah. Same thing in Hartford, but Joe is right. We started with a high bar since these folks were at one of the few and great comprehensive stroke centers in the country. So we had a high bar to achieve further improvement beyond what a comprehensive stroke center does every day of the week. And as George was mentioning, we were able to impact a very important risk factor, which is high blood pressure, which is so key, not just for preventing stroke, but other types of bad cardiovascular outcomes.
Yeah, and I know that some of those changes you just can't see in a year. So blood pressure change in a year, you may not move the needle greatly about stroke risk or even cognition, but it's the accumulation of 5, 10 years that happens. So what I was going to ask is, how exportable do you think this is to not just comprehensive centers, but other places in the country where we could do a lot better?
It's an excellent point, Joe, because the number of comprehensive stroke centers in the United States is about 200. Number of primary stroke centers is about 1,500, and then you have thousands more hospitals that are neither. So I think that's some of the low-hanging fruit, is to take some of the lessons that learned from this and then export that to those other hospitals where you could have a really big impact that would probably be statistically significant at the end of the day.
But if I can take the prerogative to ask a question, as one of the active centers, one of the integrated centers, are these activities still going on at your shop? In other words, do you still carry this forward, and are these activities still having an impact?
It's a great question. Unfortunately, not at the level that they were at when we had PCORI funding, which unfortunately has expired. But we did learn some valuable lessons about patient communication, this nurse and educator team to bring resources to the patients. So again, I think some of it is exportable, even though the study has stopped.
And so when you finish a study, it's sort of like, what's next? So how do you take what you learned and how do you make either another study or how do you move this, forward in our practice across the US? So any thoughts?
Yeah, I think one of the things we can do is to export this and use a regulatory agency like the Joint Commission that certifies stroke centers, and to take some of the lessons learned and try to incorporate that into the Joint Commission certification program so that the legacy of this is not stagnant. It can grow and expand and go forward.
And as far as the research, I do think that I have to say I was amazed that it did not have an impact on the functional and quality of life outcomes. It was a surprise to me, given the positive impact we had on the what we consider the intermediate factors. And so I think from a 2020 hindsight, I wish our follow-up had been substantially longer and give more time for those changes in blood pressures and changes in diet, changes in LDL levels to have an impact on the function and quality of life of the patients.
Perfect.
The other challenge that we had to overcome in the study, nobody's fault, it just was, is this study was happening in the middle of COVID. So we had all of those COVID things for patient recruitment, sending patients or sending our staff into patients' homes with the isolation and all of those other challenges. So the fact that we had positive impacts in the setting of those challenges, I think is another positive attribute.
Right? I can't imagine a more unfortunate study design than implementing an intervention for in-home visits in the midst of the COVID
Pandemic.
yeah,
Yeah,
pandemic.
yeah. So,
Deadline.
well, it's great work, and we obviously have a lot more work to do. Both has the U.S. population. All of us can make those changes, but as physicians, as healthcare providers, how we can take example of something and incorporate it into our future practice and our maybe our even our future infrastructure of the health of how we can do things. But thanks so much. Great talking with you. Great study.
And thank you for your
Thank you.
time.
Thank you.